This conference will now be recorded.
Okay, Dr. Feibel, you're ready to go ahead with the...
Okay, it's August 12th, 2020. The telehealth meeting will come to order at 3:35 with the following members present. Dr. Schottenstein.
Here.
Dr. Bechtel.
Here.
Mr. Ganadakis.
Not here.
He was. Wasn't you just here a second ago?
No, he's not here today.
I thought I heard his voice. Dr. Soin.
Well, that was my voice. I'm here.
Oh. I don't think it was your voice. It sounded like him. Anyhow, thank you. And myself, Jonathan Feibel. We framed the discussion earlier in the board meeting, so I'm not going to repeat the things that we're going to go through today. But prior to doing that, we need approval of the minutes.
I've reviewed the minutes and moved for the approval. Okay.
Thank you. All in favor, say aye.
Aye.
Opposed, same sign. The minutes are approved. All right, I think I'm going to turn it over to Nate or Stephanie to discuss the amendment and the legislative updates.
Sure. Actually, I'm going to, I think how we'll break it up. Jill will give us a quick readout on the legislative process itself, just kind of what's going on with the bill and what she's been hearing. And then we'll turn it over to Nate, and Nate will walk us through the memo of the draft legislation that he created in response to the input that we received at the first ad hoc committee meeting. Does that sound right? And Nate, did you have something earlier that you were going to jump in on?
It was just a small correction to the minutes. On page 7 in the first paragraph, it said asynchronous related to Dr. Soin's comment, and it should have been synchronous, I believe. I mean, it's one letter, but one letter makes a big difference in this case.
Yes, that's the difference in the word. Yes. Do we have to re-adopt those minutes now? Kim, you're good? Yeah.
Probably should, yes.
Yes.
So can I have a motion to approve the amended minutes with that change?
So moved. Second.
All in favor?
Aye.
Opposed, same sign. Okay, they pass. Thank you.
Wonderful. Thank you. Okay, Jill, please, legislative update.
So House Bill 679, as we all know, is the telemedicine bill. And as we talked about earlier, it did pass the House on 6/10. It was assigned in the Senate on June 12th. It has not yet been assigned to a committee. And that is something that we are watching and are in contact with both. There's a chance it could be assigned either to the Health and Human Services Committee or to the Insurance Committee. And we're in contact with the aides of both committees, monitoring and contacting them to see if they have any idea when it's going to be assigned. Since the Senate adjourned for the rest of the summer, which is until September, we're assuming that there's not going to be any committee hearings, and that is what we have been told. But we are going to continue to follow it. But, having said that, this is such an opportune time for us to get this finalized so that when everything does happen, we're ready and we can hit it hard. So I appreciate the efforts of this committee to get that done.
Great. Thanks, Jill. All right, Nate, I think next, you want to walk us through your memo of changes that we have in the draft on those 4 major points.
Sure. Thank you. So I really broke it down based on our really thorough discussion on July 23rd, individual visits, consistency in the standard of care, getting the rulemaking authority correct, and the synchronous technology. To start with the initial visits, in C1, basically laid out a standard that in order to use telehealth, there'd have to be a determination by the healthcare professional that an in-person visit cannot occur without endangering the patient. So it is, following the board's advice that it should be the exception to the rule that you're using telehealth for the individual visits, but it does provide a pathway for a situation like Dr. Bechtel had described, where someone was immobile and unable to come in for a visit. And then it also makes sure that there's some checks on on this process so that someone can't just claim that it would endanger the patient. You have to put it in the medical record, and in addition, added the synchronous requirement. And then the last thing, I had a good discussion with Kim Anderson about the cross coverage. So I added in in C1 small b, I added in a provision for cross coverage. So the patient wouldn't be a brand new patient to the practice, but it could be potentially, for someone who's doing cross coverage, could be their initial visit with that patient, and that would provide an exception in that regard.
Can I ask you a question about that? Because, so for instance, our practice is 60 people, just as an example. So if one of our hand surgeons has an established relationship with patient X, and then patient X has a foot and ankle problem, I still believe that initial visit with that patient, my initial visit with that patient, should be in person rather than via telehealth. So if I'm following up that patient for the same problem as the other physician, I because I'm cross covering, that's a different situation. But I think we need to be careful about this, because most patients in our big practice, for instance, are not new patients, and I suspect that's going to be the case at a big health system like OSU or Cleveland Clinic or one of those places as well. That technically they are established patient of that institution. So I think that language needs a little bit of cleanup. Maybe I know what you're trying to get at, but I don't think it achieves what at least what I perceive the committee wanting it to achieve.
So perhaps some guardrails around being seen for the same problem.
Yes. Does anyone else have any comments about that? Like,
well, I have some comments, but not about that.
Go ahead, Dr. Bechtel.
One comment on initial visit, whether than instead of using the terminology endangered, that televisit would be necessary to avoid significant compromise in patient care, rather than creating like a life-threatening situation. It would significantly compromise patient care by not doing the televisit. I was just thinking of terminology.
I was going to get at that also, because using the term endangering the patient is pretty restrictive. You know, there are probably not going to be too many examples of a situation where it's literally dangerous for the patient to go to the doctor's office, in which case essentially telehealth is not an option. So what we're basically saying is you can't use telehealth unless it's dangerous for you to go to the doctor's office. I guess I just sort of wondered if there was a way to say it in such a way, for instance, as, you know, the healthcare professional determines that the patient's health condition requires telehealth services and a telehealth visit does not violate the standard of care. You know, saying it that way. Because we are, on the other hand, you know, making the point that we feel like the standard of care needs to be equivalent, right? So if we're not violating the standard of care, does that satisfy us?
I think that's what the as passed House version had, and my takeaway from, and I'll defer to Dr. Feibel on this, my takeaway from our discussion was that we were really trying to make it so an in-person initial visit was the rule rather than the exception.
Yeah, I would agree with that. I also don't love the word endangering, but I also don't like the change. Personally, don't like the change that Michael has set up, because I think if we're going to have to regulate this with minimal standards of care, it's going to be impossible to regulate that with what you said. Because I could always just say, well, my opinion was that they needed to have televisit. It was helpful for them to have a televisit, versus what I think we're trying to say is, look, if the patient's infirm and can't get out of the house, or has a psychiatric condition like you treat and doesn't feel comfortable going to the doctor's office, that's a perfectly appropriate telehealth visit. What we need to put guardrails around is people using this indiscriminately, which is what I think will ultimately happen if we don't have adequate guardrails. And I realize that we can't protect from everything, but I think if we have really loose language, it'll never be able to be enforced in any way, shape, or form.
How
Okay.
about something like physically incapacitated?
I hear this a lot, from a lot of people, and we talk about telemedicine. And one thing I want to be sensitive to is legislating to protect the minority. I mean, do we have evidence to show that there'll be rampant abuse with this? I mean, I don't know.
I don't know how you would prove evidence at this point because it hasn't been used yet. I know a lot of health systems want to use this to expand their catchment area and be able to treat more patients. Which again, I guess if you can meet the standard of care is not the end of the world, but I just don't know how you're going to regulate it without some pretty strict parameters that basically say this is not the rule, this is the exception, that you should be using this on the initial visit to establish a doctor-patient relationship.
Yeah, I think that sounds reasonable. And I agree. I think it's very important to protect the public from abuse. I was just asking the question just to understand the scope, because I guess I get concerned with legislating around hypotheticals that may not be true. But at the same time, we're dealing with people's lives and health, and protecting that's extremely important. So I agree with what you're saying, Dr. Feibel. I was just curious to understand if we had models out there that may have demonstrated a concern.
So how about if we work on that language of endangering and try to come back with something else next time that is a little less strict? Does that seem reasonable to the committee?
Maybe just a little less, right? Because what you were saying before about, for instance, my patients, it's not how shall I say, it's not dangerous for a patient with agoraphobia or with, problems like that to come to the doctor's office, but they're just not going to come. I mean, I'm just sort of trying to work around whether or not it literally has to be a standard of endangerment, or if there's some area in which we could say, even if a patient's not endangered, that there would be legitimate exceptions if it's in the best interest of the patient's health.
Right. I think I will work on that and come back with something.
Can I make one comment?
Please.
What about incapacitated? If you're incapacitated, that kind of is a broader term. It isn't endangered, right? Incapacitated physically, whatever. And secondly, I think the one concern here is, especially with controlled substances, right? I mean, that if you remember the whole online issue with the internet pharmacies and the docs, I mean, that's what we're trying to avoid, right? I mean, are that concerned about, if someone pulls in for an allergy tablet or something? I don't think so. But I think it's more the abuse potential, isn't it?
I think we're definitely interested in opioids, but my personal opinion is we also want to make sure that people are getting the care that they need. And ultimately, a doc could easily set up a situation where they just run patients through a telehealth practice, make their whole practice telehealth, and that is not going to ultimately be in the best interest of the patient.
Yeah, you have to have a physical exam. I'm totally with you on that. I'm just saying that going down the road, I mean, after you've done that, how much more do you need if it's an ongoing relationship? That's all.
This is only for the initial visit.
Correct. Yeah. And I also want to make a comment about opioids and pain medicine, because obviously I'm very sensitive to that. Keep in mind that the DEA itself, who gives us our certificate to prescribe controlled substances, have rigid guidance. Of course, those are suspended because of COVID, but long term, they have rigid guidance on face-to-face physical exam to actually write and dispense an opioid. But in our rules in Ohio, which I presume will persist and continue, we have some rigid rules and definitions that would provide guardrails to prevent abuse from telehealth. But I hear Dr. Feibel's complaints loud and clear. Oh, I'm sorry, concerns loud and clear, because I think he's spot on correct. There will be some people out there that, if you give them, free access, that they'll take advantage. And it's amazing how just a few practices can cause significant societal harm. I mean, we saw the opioid crisis in Ohio literally generate out of one city, Portsmouth, and percolate to almost the entire state just from 9 practices. So it really doesn't take a lot to cause a significant harm. So I appreciate that concern that Dr. Feibel has about the initial visit.
I appreciate it, and
I think
oh, sorry, I was just going to say, if it's ultimately, the strict language that the committee wants to use, I'm very respectful of that.
I think it is important that we don't deny access of a first initial visit with a televisit for patients that are immobile or have other major health issues that would prevent them from coming to the office. I had patients with rashes that would, in the past, required an ambulance to take them from Chillicothe to Columbus and spend $400 in transportation for something that could be, with really good quality care, be diagnosed with a televisit. So I think there's situations where access to people with really important medical issues could be denied because they're immobile, difficulty moving, recent orthopedic injuries, for instance. There may be situations where we might deny access to people that need care because they physically can't make it to an office.
To allow for that, for both of your concerns, right? I would think.
Yeah, and I think the legislature is going to want that. So I think it's important because they're going to want patients to get access who can't otherwise get access. So I think it's important to find the right language there.
I will work on kind of tempering that language.
Okay.
Thank you so much.
And the one other thing on the cross coverage issue, we do have a definition in, I believe, 4731-11-01 that kind of limits cross coverage. So I'm going to work with that definition and try to perhaps include a reference or in some way make it so it's clearer that we're excluding the situations where, it's among the whole Cleveland Clinic practice and really to somebody who has an actual cross coverage agreement with another physician. So I will try and tighten that up as well.
Next.
Yep. So the next is consistency in the standard of care between in-person visits and telehealth visits. So that's in D2A. There are a couple of things we talked about in this. One, you wanted to preserve the consistency between telehealth and in-person visit standard of care, but in addition, we wanted to create an exception for situations such as present time, an emergency. So I have added a reference in there, except in an emergency as defined by the statute, which that statute's been used in other legislation where I believe it's 5502.21E. So it makes an exception that if we're under a pandemic, that would be lifted. And then to harmonize the legislation, the previous Division D, which talks about civil liability, we would propose striking that division. Those were all consistent with the direction from the committee a couple weeks ago. Any questions on that? Okay. On the third one, the rulemaking authority of the board, just really some small changes in there. Took out the word fully as it relates to informed consent. I think that was kind of a loaded word that we had talked about before that probably wasn't necessary. So that was taken out. And then in all of our discussions about synchronous and asynchronous, thought it would be good to also add I believe it's D1H, technology requirements to meet the standard of care. And then also previously I had borrowed some language from the teledentistry amendment that had talked about the requirement for dentists to have written protocols on site. And so I took that out based on our previous discussion that we wanted rulemaking power and not to sort of do a hybrid of rulemaking and protocols and really just muddy the waters and just make it strictly rulemaking. So any questions on part 3? Okay. And then the last part is the synchronous technology. As I read through it again this morning, I found there is one typo at the bottom that I will correct. The word patient is repeated twice. I believe in C3.
3A.
Yeah, so I will take that out. But the point of this was to have the default be conducting telehealth via synchronous interactive audio and video elements, except, and then we had talked about 3 different types of exceptions. One, we talked about the CPT codes maybe not requiring it. So that was the purposes of little I, that visit with the healthcare professional is strictly for a verbal consult or verbal counseling, and the standard of care doesn't require an in-person exam. 2, the situation where people have tried in good faith to connect via synchronous technology and something just goes wrong with the technology, and that they shouldn't be penalized if they're trying in good faith to conduct telehealth via that. And then the last one is, I believe, the access situation. The patient doesn't have access. I would anticipate softening that language about endangering the patient, similar to the language that we'll be softening on our first part that we discussed with the initial visit. Something closer to what Dr. Bechtel suggested about necessary to avoid significant compromise of the patient's health, something to that degree. So any comments or questions on that part?
Hi,
Dr. Schottenstein.
thank you so much. So I was just looking also at 3A1. And I was wondering if we could even potentially strike the first part of that, where it says the visit with the healthcare professional is strictly for verbal consult or verbal counseling, and instead just have it read, the standard of care does not require an in-person physical exam. In other words, do we need the whole first part of that?
Dr. Feibel, I think we lost you.
No, I'm here.
Oh, you here? Okay.
I'm thinking through that. I don't. At first blush, I didn't love that whole statement, but hopefully this doesn't affect billing at all, because people are not going to want to do that unless they have to, because you can't bill for it, or you can bill a very small amount for it, versus true telehealth that requires a video. So I don't think people are going to be using that unless practitioners try to use this statute to say you should pay me for a telehealth visit. So I don't have a problem with what Michael's saying. I don't know if anyone else does.
I guess my one, I think I see what Dr. Schottenstein's trying to do. My one, I guess, reservation is, we're being very clear in D2A that the standard of care is the same for telehealth and in person. And by taking out the first phrase, it's sort of making it seem like there's a different standard of care.
I also don't have a problem leaving it in. I don't think it's a big issue either way. Dr. Bechtel or Dr. Soin or Mr. Jackalone? Anyone?
So Nate, do you have the sense then that the way it's worded right now is consistent with like a 99443? Like that's a legitimate purpose for it, is to, continue to have that option?
I'm assuming what you mean by 99443 is it's a CPT code for verbal consult?
Pretty much, it's like a Medicare approved phone consultation.
I think it's 99.
That was the,
I think there's a few.
99442.
Yeah, there's that. It depends on how much time is spent on the call.
the intent and maybe the wording didn't get us all the way there, but the intent was to cover situations where it's able to be billed. There's CPT codes specifically for these type of verbal consults. So that was the purpose.
And I don't know if you guys all saw, last week Medicare issued their preliminary fee schedule for 2021, and the telephone visit, not telemedicine or whatever, the telephone visit code for level 3 was like $88, which was consistent with like a telemedicine visit. So the reimbursement for those codes for at least 2021 preliminarily seemed robust.
Then maybe we should keep it in there.
Okay.
All right. Anything else? Anyone have any? Are you okay, Michael, with keeping that in there? Or
I think for now, I'm just sort of, thinking about, doctors who want to, communicate, with their patients by phone. And what I don't want is for us to go backward and become, as we're trying to expand things, to unintentionally restrict things. At the very least, I think we should have the abilities going forward that we already do, right? And not, restrict further what can be done with the synchronous technology.
I think it, again, is important not to restrict access to elderly patients with significant health issues that just simply don't have an iPhone with a camera.
So that was actually something else I was going to bring up, which is that's potentially another exception, really, which is to say an ability to use the equipment, right? You can have people who have the equipment, they don't know how to use it. And I had a friend the other day who had to drive to Toledo to help an elderly person to use her equipment for an appointment with a doctor. She had the equipment, she just didn't know how to do it.
I think that's kind of covered in number 3. Patient does not have access. I mean, if they don't know how to use it, they don't have access to it.
Okay, fair enough. That's fair.
I don't think anyone's going to argue with you about that. So I think that's covered.
Okay, I wasn't sure.
And I think that allows elderly people to use this. I mean, that's a good. There were plenty of my elderly patients that I tried to use telehealth with. They couldn't make their iPhone work right, or couldn't do it right. So it would still allow them access based on this. All right. Well, I think we accomplished a lot today. We'll bring back those few changes. I don't think we need an interim meeting unless something starts moving in the Senate pretty quickly. Is that everyone's feeling?
For now, yeah, sure, absolutely.
And obviously, if something starts moving quickly and you need our help, Nate, we'll get together quickly.
Dr. So, go ahead, Kim.
I just wanted to ask, we've had some attorneys contact us with questions that are coming from hospitals. So they're attorneys representing hospitals and hospital physicians, and they have some questions about the application of our current rules. And I thought if we need to expand some FAQs in the meantime while we're waiting for this legislation, would this committee be a good place to bring that?
Yeah, and I think that's a great idea, not only for attorneys, but other people that might.
Okay. All right. I've got a couple of pretty detailed requests. I think we can plan to bring those for September if we're having a meeting in September. But I just wanted to see if people thought that would be appropriate.
I think it is.
Okay.
All right. No further business. Motion for adjournment.
So moved.
Second.
All in favor?
Aye.
Aye.
Opposed, same sign. All right. Thank you so much. It's 4:06. Have a great couple days.